Ariel Carpenter. I'm presenting this case along with Ryan Connard and Jennifer Olges, representing the University of Louisville, entitled A Thirst Quenching Conclusion, an Atypical Presentation of Neurosarcoidosis. First of all, just to understand that sarcoidosis is a systemic autoimmune disorder that's characterized by the formation of non-caseating granulomas throughout the body. Given the diffuse nature of these granulomas, there is significant multi-system organ involvement, and within that multiple organs involved, CNS involvement is reported in a minority of cases, approximately about 3 to 10%, and typically appears as a cranial nerve palsy, often as simple as Bell's palsy. However, an even smaller subset of these cases involves the hypothalamic pituitary axis and results in endocrinopathies. We present the case of a 40-year-old male with a history of anxiety and sarcoidosis who presented with a 2-day history of shortness of air that was associated with 2 weeks of worsening odonophagia and dysphagia. He was already followed by outpatient pulmonology and dermatology for his known sarcoidosis and had been undergoing treatment with hydroxychloroquine and adalimumab. He reported, in addition to prior symptoms, decreased oral intake for the last 2 days, which really stood in stark contrast to what his family reported as significant water intake and trips to the bathroom when they had been visiting him. Additionally, he reported worsening anxiety and even some new onset paranoia that had resulted in initiation of alprazolam as an outpatient. At the time we met him on admission, he was afebrile, however was hypoxic, requiring 3 liters nasal cannula with 94% oxygen. He was mildly bradycardic to 53, tachypnic to 28, and was normotensive. He did appear anxious but non-toxic. He had bilateral crackles in his lung bases and had significant dermatologic findings with diffuse red-brown dermal plaques, notable on the bilateral upper extremities, back, and chest. His initial lab findings were significant for leukocytosis, mild anemia, and severe hypernatremia to 167, as well as some mild hypokalemia, acute kidney injury, and subsequent laboratory studies that are noted here in this middle column indicated normal TSH, but a low free T4, indicating an inappropriate response, undetectable ACTH, and a low normal 8 a.m. random cortisol. In addition, he had a low and low normal LH and FSH, respectively, and an elevated prolactin. His hospital course from there was notable for prompt involvement of endocrinology, for management of suspected panhypopituitarism and diabetes insipidus, and high-dose glucocorticoids and DDAP were initiated, as well as maintenance IV fluids. Unfortunately, within 2 days of his initial hospitalization, he experienced worsening respiratory failure that required intubation, mechanical ventilation, and ultimate tracheostomy for stabilization. Chest radiograph was obtained that demonstrated subglottic stenosis, as well as likely pre-existing bilateral hilar lymphadenopathy from his sarcoidosis. ENT was involved and noticed significant mucocutaneous lesions that were concerning for sarcoid-related changes that ultimately led to his respiratory failure. In addition, his hospital stay was complicated by AV block and persistent bradycardia that briefly required intravenous cardiac pacing. However, cardiac MRI and echocardiogram were unremarkable for infiltrative lesions. Once patient was appropriately stabilized, his respiratory status has improved, he was able to undergo pituitary MRI, which indicated diffuse changes consistent with neurosarcoidosis. You can see here on this MRI where we have 2 different views and contrast phases, that there is heterogeneous patchy enhancements in a variety of locations from the pituitary gland, infundibulum, optic chiasm and tracts, anterior corpus callosum, anterior commissary, and adjacent cingulate gyrus. And really, ultimately, this was felt to be consistent with the appearance of neurosarcoidosis. Following his stabilization, he was continued on high-dose glucocorticoids that were tapered at the time of discharge with plan to initiate infliximab at all patient follow-up. This case represents a atypical presentation of an already rare condition and really illustrates the wide variety of pathology that can result from sarcoidosis and the need for early clinical recognition prior to deterioration. Our patient's inability to maintain his prior high free water intake due to his severe skin and mucosal diseases ultimately unmasked his sarcoid-induced diabetes insipidus and led to the recognition of his neurosarcoidosis. It's important to understand that neurosarcoidosis almost never spontaneously regresses and almost always requires treatment. As we experience in this case, glucocorticoids remain a cornerstone of disease management. However, in addition to other immunomodulators, recent evidence has really highlighted a key role for infliximab, not only in systemic sarcoidosis, but also within the subset of neurosarcoidosis. And multiple recent retrospective studies have found a high efficacy and safety with use of infliximab even in refractory cases. And that's important because within this disorder, there is unfortunately a high prevalence of that to initial treatment modalities. The neuroendocrine disease in this case also represents a potentially irreversible sequela based on the data that we have, in contrast to other forms of neurosarcoidosis. And this really highlights the importance of prompt treatment and recognition. To conclude, neuroendocrine sarcoidosis is an atypical form of an already rare disease, neurosarcoidosis. In patients with sarcoidosis, clinicians should have a low suspicion to evaluate for neurologic and hormonal sequelae if the patient experiences an abrupt clinical change. And infliximab is a key and emerging therapy for neurosarcoidosis. However, it is notable that there is a lack of higher quality evidence in the form of randomized controlled trials that outline its efficacy. And this is largely due to the overall rarity of the condition itself, which does present a challenge in the gathering of this data. Thank you for listening to our presentation and for your attention.